Hey guys, I'm just checking in here to help you guys out with the last couple mental illnesses that you guys are to be working on. And the last two biggies wind up being schizophrenia as well as dissociative identity disorder or dissociative disorders as a whole. I wanted to start off with schizophrenia itself. Schizophrenia affects less than 1% of the world's population, but it is arguably one of the most debilitating disorders out of the entire spectrum of disorders in the DSM 5. Schizophrenia is now considered to be a spectrum of disorders, kind of like autism would fall along a spectrum as well, meaning that there is not just one type of schizophrenia, that there are several types of schizophrenia, just like there are several different types of autism. Whether you were to talk about, say, Asperger's, or you were to talk about individuals falling under what is, say, savant syndrome. Schizophrenia also has several different forms of schizophrenia as well. If you were to talk about, say, individuals who are more residual, if you were talking about the most common type, which winds up being paranoid schizophrenia. Paranoid schizophrenia winds up being a form of schizophrenia that individuals very frequently believe that individuals or items or the government or what have you are out to get them or hurt them. And schizophrenia as a whole winds up being loosely translated to split mind. A lot of individuals feel that schizophrenia and dissociative identity disorder should be interchangeable. Hollywood, TV shows, even people on social media use them interchangeably. And I want to make it very clear that they are not the same thing. They are two very, very different disorders that have different characteristics. Schizophrenia usually makes its onset in the early 20s to early 30s for both men and women. Men typically wind up developing schizophrenia a little bit later on in their 20s, and women typically wind up developing schizophrenia a little bit earlier in their 20s, but 20s to 30s is typically the age of onset for schizophrenia. Schizophrenia has what it considers to be both positive and negative symptoms, though there are certainly disorganized symptoms too. Positive symptoms wind up being items that are in addition to societally acceptable behaviors, such as hallucinations and delusions. A hallucination is a false perception. It could be any of your five senses, but in that particular case, most people think about hallucinations as hearing voices or seeing things that are not there. But certainly they can go along with olfactory or tactile-based hallucinations, though they are rarer. Delusions, on the other hand, typically wind up being false thought processes, such as the government is spying on me, or that the FBI has tapped my phone line, or anything along those sorts. Typically, delusions go along with paranoia, that people are out to get them and people are out to harm them. Hallucinations and delusions usually wind up manifesting together, though the most common type of hallucination winds up being auditorily based in hearing voices. A fun note is that American-based hallucinations are often drastically different than, say, African-based hallucinations or Asian-based hallucinations. American-based hallucinations are usually much, much, much more menacing and threatening in nature. It has been misperceived or misconceived due to the press and TV and movies that hallucinations often wind up making people do things to hurt other people. And while there are certainly exceptions, such as, say, the Son of Sam murders, in which the gentleman received orders to hurt individuals from his neighbor's dog, those are very, very, very rare and few and far between, but they get blown out of proportion by other individuals, and therefore that's what individuals typically think of because they see it on TV and read about it on social media and maybe even have specials on it based on Netflix. If you talk about negative symptoms are behaviors that are lacking that should be there. Like a really good example would be having a flattened affect, that individuals have an emotionless face. Another example would be alogia. And alogia would be without speech, or the ability to produce quality speech. And that kind of starts to blur the line into the disorganized behavior. And very frequently, schizophrenics are disorganized in their dress and their ability to take care of minimal personal hygiene, such as, say, bathing regularly or making sure that they are eating regularly. Disorganized based behaviors are very, very easy to notice, and it's equally as easy to notice when individuals wind up displaying a disorganized behavior called, for lack of better term and slang term that is acceptable, a word salad. That individuals know what they want to say, but their words are all jumbled up and their syntax and their grammar just doesn't wind up adding up the way that it should be. Schizophrenia winds up attacking two main portions of the brain, and that would wind up being the thalamus as well as your amygdala. The amygdala, as you guys remember, is used for your fear center, and the thalamus is your train station for virtually all information. And because of that, both of them are very much linked into the dopaminergic system. So the theory is, as of right now and is most well understood, that individuals with schizophrenia have too much dopamine in their system, which might very well wind up causing their schizophrenic-based behaviors, their emotionally driven behaviors. Schizophrenia is typically treated by use of antipsychotic medication, whether you're talking about Haldol or if you're talking about Thorazine, and there are many others that go along with it. Antipsychotic based medications are not meant to be stayed on for a very long period of time. If individuals stay on antipsychotics like Thorazine for too long, you can wind up developing tardive dyskinesia, which can wind up being life threatening and causing symptoms very, very similar to Parkinson's disease. Those symptoms wind up being irreversible. So the individual needs to be watched clearly by a team of physicians as well as therapists. With that being said, the discussion on schizophrenia is left to be parsimonious. I also wanted to briefly touch upon dissociative-based disorders. The most commonly or most well-known dissociative disorder winds up being multiple personality disorder, or what is now called dissociative identity disorder. That particular disorder is based on that the individual should have two or more personalities living within their psyche that take on different characteristics. It is possible for different personalities to be of different genders, different intelligences. There's even been documented cases of different personalities having different medical conditions. One personality may wind up being diabetic and another personality may not need insulin. One personality may have one type of vision problem and the other personality may have a complete and total fine visual acuity. So the big thing that comes into play with dissociative identity is that individuals who are diagnosed are heavily scrutinized. And a very, very good example winds up being the case of Sybil. With that particular case, it was heavily thought that this woman had multiple personalities living inside of her, and it was one of the most well-known and well-received types of multiple personality disorder. Unfortunately, as time went on, that was debunked and it was actually let out to be a marketing ploy, and that she did not have multiple personalities. And while she did have, which is a characteristic of dissociative identity, she did have an abusive childhood and she was abused heavily. She did not have multiple concurrent personalities living inside of her. And one of the biggest criticisms of dissociative identity disorder winds up being that individuals with dissociative identity are not knowing that they are transitioning between those particular personalities. It is heavily scrutinized. There are lots of different doctors and clinicians that would say that dissociative identity disorder does not exist, and that those individuals who have been diagnosed with it have been done so because either A, they are being used as a publicity stunt and for the doctor or team of clinicians to get more research out of them, make almost a spectacle out of them, or because the individuals are acting out a role that doctors and clinicians have told them that they need to hang on to and continue showing characteristics for. There is no great treatment for dissociative identity disorder. Theoretically, the treatment method would be to have those personalities confront one another until the most powerful personality was to triumph and remain within that person's psyche and personality as a whole. And it sounds very hokey, and in my personal opinion, which is only my personal opinion, I agree that it sounds very hokey. So I'm hoping that with this light lecture, you guys see the difference between schizophrenia and dissociative identity disorder. There are two very, very different disorders that should not be used interchangeably. I hope this message finds you guys well, and I hope that your other studies and your other courses are going well too. Please reach out if you should need anything. It's been great lecturing to you guys this week, and I appreciate all of your efforts. I look forward to talking to you guys soon. Be well and take care of one another.